field that is not going to be out of my line of sight, but is also easily accessible. Okay, I'm not a big fan of putting it, you know, right behind you, or even like this is a little too much. But I like that curve, so it's sort of a, you know, a little bit more than 90 degrees. I'm able to keep an eye on what's going on in my sterile field. But I want to make sure I do things like adjust oxygen and such before I set up sterile field, because if I turn my back on it, what happens to it? It's gone. Right. So we'll start with, and you're going to do this in Skills Lab with a mannequin in the bed, just like this. They're all set up in there right now. You should have trachs in everybody. And there should be ambu bags at every head of the bed. You have a mask in your kit. And I think they all have trach masks on. If not, we'll pull those out so they do, because I want you to practice that part too. So most of them are going to have some kind of oxygenation on, along with the ambu bag that we're going to use. Now, for the sake of safety, everybody's going to wear one of these when they do this skill in real life. I'm not going to wear it while I demonstrate, because you can barely hear me talk through this. Plus, I get really hot if I'm talking. And for testing, I want you to bring it and demonstrate to your instructor that you would have this on the whole time. The minute you pretty much walk in the room, if you've got somebody who has a trach, who has a lot of secretions, right, you really want to protect mostly your mouth and your eyes. So protection for this. If you feel the need to wear a gown around that patient, because you know they're going to spew some stuff out once you start stimulating their, you know, cough reflex, that's fine too. You want them to cough while you're in there, even if it looks like they're uncomfortable, because that's helping loosen it up. You don't want to over-suction, though, or do it too frequently, because why? Yeah, too much suctioning actually results in more suctioning, because then their airway's irritated, it's traumatized, more secretions, they keep coughing. So you really want to be in and out quick. You may not even use your 3 chances, right, that we give, but you want to make sure that you're effective. If the patient's alert and oriented, they're usually pretty good about letting you know that they feel like they need suctioning, you know, and they'll let you know when they feel like it's enough with gestures and such. If they are not, then you kind of have to use your auscultation skills to determine that their airway sounds clear. Look at their sounds. So part of this procedure, as you knock on the door, come in the room, and wash your hands, is to identify the patient and then go ahead and do a respiratory assessment on them. Now, you don't have to necessarily do that whole thing in lab, but you need to at least verbalize that you would be assessing their respiratory status, listening to their lungs, checking their SATs, making sure they don't look like they're in any shortness of breath or respiratory distress or any of those kind of things. So we've established that he's not in distress, but that he does need some suctioning. So I'm going to go ahead and prepare my workspace here. I want to clean my table. Somebody spilled something on it. That is not uncommon in the patient rooms to see stuff all over it. And you're going to set up sterile fields here, so it's nice to have a clean workspace to get started. So, other things you're going to do in preparation, you're going to make sure your suction works. You're going to make sure that the tubing is connected to the suction canister. Right here. Check the suction. Make sure it's on and working, and have that close at hand. You will plug in your ambu bag. Now in the lab we only have one oxygen connector, right? But in the hospital, most of the time if you're dealing with a patient like this, they'll have one for their oxygen, but a second one you could plug this into. So you would discuss how you plug this in, and you would have it at, you know, full blast, 15 liters or whatever, so that you can use that to hyperoxygenate your patient. So the ambu bag's plugged in. We're going to have that nearby. For the sake of testing, you can have an assistant help you with the ambu bag if you need help. So I'm probably going to try and do it with one hand here. It's pretty tricky. But for your purposes, I want you to ask your instructor to be your assistant, and I want you to explain to them how to do it, as if they're a CNA and they don't understand how to be sterile or anything. And basically, it will just be a matter of placing this over the tracheostomy, connecting it on there, and squeezing 3 times nice and slow in between each time that you suction. So before you suction, and then after you suction, then you give them a chance to recuperate. Actually, let me put that a different way. Before you suction, so you ambu bag, you suction, give them a rest period, ambu bag, suction. Okay? Yeah. And think about that for a minute.
So to have an assistant, it just makes it like less time.
It's really hard to do this with one hand. You're going to see me.
Okay.
You're going to have a sterile hand. You can't do it with one hand. And you can do it before you put your sterile gloves on, but then the next time you have to do it, you're only going to have one hand. And so it's easier to have somebody help you with that. So I'm gonna go ahead and open my brand new clean sterile suction kit here. And the first thing I should find is my gloves, but also, let me put this in the right way. When you see the little box, this part should be sticking out, okay? So that you can remove it, touching the non-sterile outside bottom, okay? Not the inside, but this outside is non-sterile. So you can touch that part, remove that. Remember to pour your saline in before you glove up, because you can't do that after. That's another one people miss. So pour my saline in, you can just pretend. With the saline, you need to time and date it for 24 hours. If you do remove the cap, obviously, you have to make sure you keep that sterile, you don't touch it, okay? And you don't touch the inside of the cap. So I would pour it in and then recap it. It's labeled. What is an alternative way to get saline for this? Flush. Yeah, you can use the saline flushes. Squirt a couple of those in there. They're nice and sterile, right? And then you don't have to deal with the bottle. But if not, you can use the bottle. So I've got that. Then I'm going to go ahead and take out my gloves. All that's left is my packet here. And just like the, can you guys see this? When you open this kit, just kind of like other things, you want to open it away from you, like the dressings, remember? And that outer edge is your sterile, non-sterile part. So I don't really want to touch this. That's a backup sterile space if I need it, okay? So if somebody wants to stand closer to see, record. So I've opened in my kit, I've taken out my box, I've filled it with saline. I'm going to remove my gloves. I've checked that my suction is working. And assess the patient. This says saline. I'm just thinking through my steps. Suction is ready. So I'm going to go ahead and put my sterile gloves on first. Some kits only come with one glove. So then you put one sterile glove on and one clean glove. But for our sakes, we're going to pretend like we have two sterile gloves, which makes it a lot easier. Right hand first, pinch. Okay, sterile. Scoop the second one. It's actually upside down. Let's turn it over. Scoop the second one. Yes. Okay. Now, right now, both my hands are sterile, so I can touch this packet and everything in it, no problem. But in just a second here, I'm going to stop being sterile with one hand, and that's going to be this hand, the non-dominant hand. So as soon as I connect this to oxygen, and I want to hold on to this little plug so I can connect it nice and firmly. Once it's connected now, the plug is non-sterile, but the tube is sterile, okay? So I still just have one hand that's clean and one hand that's sterile. So I remove his oxygen, and I either have my assistant or I go ahead and give him his 3 big breaths. 1, 2, 3. Carefully remove this. Set it aside. I've got suction. I want to go ahead and run a little saline through here, lubricate it with a little saline. And then go ahead and go in till I hit resistance. And then I'm going to do a little twisting motion while I pull it out and tapping, twisting and tapping. It's like patting your head and rubbing your belly at the same time. So we're twisting because there's 2 holes on here, but they're not really, if you want to get that 360-degree suction activity, you got to roll it a little bit, right? So I did 1 suction pass already. If he coughed, whatever, that's okay. Put his oxygen back on. Give him a minute to recuperate. While I'm waiting, suction out my tubing, make sure it's nice and clean and fresh and there's nothing clogging it up. Wait to see how he's doing. Give him about a minute in between passes, right? If he indicates that he would like more suctioning, I would then go ahead and have my assistant provide another 3 breaths for him. 1, 2, 3. He may start coughing. That's okay. All right, sir, here we go. We're going to do this one more time. Go down till we hit resistance, pull back just a little, and then tap, 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 tap. Okay, put that back on there, let him breathe, clean that tube out, stand back and wait and see how he's doing. So you see how I'm constantly, like without even thinking about it, wrapping this around my hand so that I don't, and this is the one thing students do, they're like, doo-dee-doo-dee-doo-dee-doo, and I'm like, stop! So just make sure you have it so it's not flailing around, you're keeping it safe and clean in your sterile hand. Your non-sterile hand can do anything it needs to, but you just have one hand to do that with, right? And then the other key point is the tapping and the twisting. And again, it's just about keeping sterile filled. So I don't want to turn my back on this. I don't want to, you know, let this bump into anything. I don't want to get my hands switched. Students do that all the time. They start doing things with their non-sterile hand instead of their sterile hand. So make sure that you're keeping track of which hand is which. Once I've done it a couple times, if he seems like he's feeling all right, maybe I'll stop and listen to his lungs and assume, make the assumption that he's better now or his stats have gone up, and I'm done with suctioning. And so you can dispose of the suction catheter by just pulling it into your gloves like this. And that's your trash. And I'm done. Okay? And then we'll go right into trach care. So wash my hands again and remove my supplies from this procedure. Trach care, I'm going to start off with clean gloves. I need some of those nearby. My area is still clean. I use peroxide and saline in this scenario, and again, same thing. It needs to be labeled, good for 24 hours, etc., etc. Open my kit, and usually the first thing you'll find is the little drape over here in the package. And I want to find, oops, I want to catch a corner of it so I don't contaminate it, so that I can open it up. There we go.
Is the peroxide good for 24 hours also?
Yeah. Open my drape up, and you can lay this, I've done it where I've laid it on the patient's chest, on the bed. You can put it on the table next to you. Okay? Open that up so it stays, come on, this thing's been folded a long time. There we go. All right, the next step is to dump the contents of your kit onto the sterile field. Make sure that you're hanging onto this flap. Students like to just do this thing, and the flap falls down, contaminates everything. Remember, that outer edge of that flap is not sterile. The outer edge of the box is not sterile, right? So we don't want it to touch our sterile field. So I'm just very carefully going to dump my supplies out. I'm also not going to put the kit, okay, that's all right. I'm not going to put the kit on the sterile field. It's not what I want to do. We'll take this out of the sterile field because it's not sterile anymore. And I think for my purposes, I'm going to do a little organizing of my space here. I'm going to turn this way, so I have more room to work. Here's my little box, okay? You have 3 containers in your box, okay? 2 are for saline, 1 is for peroxide. You need to figure out a way to be consistent so you remember which one you put what in, okay? Because we don't want to mix them up. I'm going to put my peroxide in the big one, because that's where I'm going to put the trach tube to soak and get clean. So it makes sense to use the big one. Second biggest one will be saline and saline, and my intention is to use the second biggest one to rinse, which then means it will be contaminated with peroxide, and I'm not going to use it to do what? Cleanse that tracheostomy stoma. So that will be my rinse, and that will be for my cleaning of the tracheostomy stoma and skin. That will be my pure saline. Okay, so I've got all that ready. I want to start off with my clean gloves. You don't have to do anything special like hyperoxygenate or anything at this point. It's just an issue of making sure that the patient is comfortable, and you keep his oxygen nearby. So I'm going to take the trach tube out without touching the sterile part, carefully place it in the saline, and then make sure his oxygen stays there. Okay. I also want to use this as an opportunity to remove this dirty dressing, because I want to put clean gloves on later. So I'm going to remove this now, dispose of that, and now I'm going to switch over to what? Sterile, because I need to touch my sterile field. And I haven't turned around on it. I haven't lost my view of it, so it's still nice and sterile. Put that in the invisible garbage.
So when you set that in the tray, did you put that in the peroxide or the saline?
Peroxide. It's soaking in the peroxide because we want that to break down the yucky stuff, right? So that's kind of our little disinfecting solution. These are all, there we go. All right, same thing. I'm going to do my dominant hand first here, holding my hands up and away from my body when I glove so I don't contaminate. If you haven't practiced sterile gloving, it's time to do that again. Second glove. Okay, sterile hands means I can touch everything here and everything inside that kit. This is the first time I can do that. Okay, so when you set things up, before now I should not have touched any of this stuff. And that's another place students fail. They start touching these things before they're sterile. So now I'm going to kind of organize my supplies. There's my new dressing. These are my little cotton swabs for cleaning around his stoma. If I want to, so I don't forget, I'll put them right into the saline I plan to use. That's a good way to remember. Here's my little scrubber, and I've got a fresh trach tie. And then extra gauze for cleaning the skin and drying the skin around the tracheostomy and around the, under the trach tie and under that shield that it has, okay? And then of course the mystery pipe cleaners that everybody asks me about, and I just make art out of them, make arts and crafts project. Did you ever do that as kids? Make little animals out of pipe cleaners? But you can use them for extra cleaning as needed. Okay, so I'm going to go ahead and come over here and start cleansing this, and you can do it over the little box, which, you know, if I wanted to really do this right, I would have had this box turned the other way. It doesn't really facilitate that with the flap. Okay, so I'm cleaning over that. Scrub, 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 dispose. Clean this with whatever I need, dispose. Then in my rinsing box, I'm gonna rinse the peroxide off. Make sure it's all nice and clean. Rinse, 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 rinse. And then over here, tap on the gauze to make sure it's nice and dry. Okay. And now, in just a minute, I'm going to stop being sterile. So I'm going to remove this. So now my left hand's not sterile, right? And I'm going to hang on to this. Go ahead and place it. And now I'm clean. So now I can go ahead. This all becomes clean. Okay. So now I can go ahead and clean around his tracheostomy, making sure I stabilize it, don't cause any trauma to it, dispose of that, grab a clean gauze, make sure everything's nice and dry, super clean, super dry, clean, 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 dispose of that, place a new dressing under. Some of these guys it's harder than others, okay? And then I'm going to go ahead and replace the trach ties now. Replacing the trach ties, you start at the side away from you. It's easier this way. I thread them through the side away from me. And if you have trouble threading them, one of these are helpful to use to kind of hook them through. See? And then you want to pull them together like this, so they go around double. Okay? Come around to the other side. As you're doing this, you're assessing his neck, the skin under his neck. Sorry, bud. If you haven't done it already, you were assessing the trachestoma while you were cleaning, right? So there's a lot of assessment in this. You know, anybody can clean a trach, but a nurse can get in there and actually assess it too. So I've assessed it. It looks great. If I see any skin breakdown or trauma, I need to notify the wound care nurse right away because these are very vulnerable patients and this area gets very moist and can break down really easily. And so there's special, you know, products they can use to help. And the back of the neck can get really irritated, especially if the patient's a little bigger and they're sweaty or whatever, you know. So if you notice, I have not removed the old trach tie yet. Tie the new one, if I can here. It's hard to tie with gloves on too. And I just use like a slip knot on here, as long as it's something I can untie later. Okay, all right. And then I'm going to go ahead and take off the old one. Again, the whole time I have my face protection on, right? Because otherwise I would not even be thinking about leaning over him like this, right? Remove the old tie, still assessing the skin, making sure everything looks okay for him. Go ahead and get this out, dispose, put his oxygen back on. And then I want to do one final full assessment to make sure that his respiratory status has gotten better instead of worse, right? I want to leave him in better condition than I got started with. Sats are up, airway sounds good, he looks good, he's indicating he feels better, and then go ahead and make sure I've set the oxygen back to whatever his original settings were if I changed it for any reason, and then just dispose of my supplies and document. And I document everything. I document the suctioning, what size French tube I used, how many times I went down, anything about the oxygenation, if I hyperoxygenated with 100% or I turned his oxygen up, whatever there I want to document. I want to document my before and after assessment of lung sounds, SATs, appearance of breathing, all those kind of things. I want to document the appearance of the secretions that I suctioned out. Are they yellow, green, thin, thick, tenacious, purulent, whatever. And then with the trach care, same thing. I want to document the tube, condition of the tube when I cleaned it. Was it crusty? Did it clean easily? The condition of his tracheostomy stoma. Is it brand new and bloody? Is it healed? Is the dressing got blood on it, or is it just got some, a lot of times they get a lot of mucus secretions and that kind of thing on their dressings. The condition of the dressing, the condition of the skin around the neck, and any other, you know, significant findings. Confirm the size of the tracheostomy tube that's in the chart, make sure that's the right size, and that would be it. Any questions on that? Any questions on the checklist? I want you guys to take a look at it now and tell me if what I did makes sense, so that when you go in there and you start to do it yourselves, you go, oh yeah, she did that, or she didn't do that. One other thing I didn't do is if your suction kit has one, and you can grab a washcloth. You can put a little washcloth or a chucks or something on their chest before you suction. That helps keep their gown clean. So it's probably not a bad idea. We can do that too. I don't know if it's in the checklist or not, but it's something you can do.
If you can't get, like, say, a previous nurse's tie undone, is it okay to cut those ties if you're careful?
I think so, as long as you've got, I mean, you have to get it off, right?
Yeah.
So as long as you've got one on there already and it's secure, I'd be real cautious, but yeah. I mean, you would have to use the bandage scissors that are blunt on the end. Yeah, I think so. And, you know, again, most of the time, except for in some home health situations, you're going to be seeing these nice ones in the hospital. These are way easier to use, and they just Velcro on. You still want to do the same thing. You want to put the new one on while the old one's still on there, but then these just Velcro, and they're much more gentle on the skin than the trach ties. But for practice, I have you guys use the string, because that's what comes in the kits. And it's cheaper. Some patients use the strings at home, because you can get a whole roll of it, you know, for $5 or whatever, and these things can be more expensive. All right, any other questions?
For the oxygen level, you're just gonna keep it on like 50 liters.
Yeah, so while you're using the ambu bag, you want that on high. I usually just either increase this, what they've got flowing here, or just leave it at what it's at, depending on the patient. But if you're not using an ambu bag, you just increase the oxygen at their oxygen source. But for our sakes, we're going to just use the ambu bag, and so that will be what we bring up to 15 liters, which is ambu bag delivers 100%, right? Because it's directly blowing the oxygen in the airways. So the higher flow is better. Yeah.
In the last step on here, replace trach ties if needed. It says to have the assistant hold the trach tube in place with gloved hands.
Mm-hmm.
Okay.
So again, it's just to prevent this from wiggling around and being uncomfortable in the patient. You don't necessarily have to have your instructor do that. You can just state, if I need an assistant to help me, they could hold the tube stable while I'm doing this. Because you'll notice, if you're really having a hard time with it, it can really get kind of wiggly and unpleasant. So if somebody's there holding it stable. Because we keep the old one on before we remove it, put the new one on, keep the old one on and then put the new one on and then remove it, we're less likely to have the risk of it coming out. And most of the time, if it comes out, you have to call, rapid response or somebody, the doc, to come in and replace it. There is some hospitals that say, well, if it comes out just a little bit, push it back in. But most of the time, if it starts sliding out, you're going to want a physician in there. And they also say to keep like one kit of a tracheostomy in the same size the patient has at the bedside, and then have one a size smaller also at the bedside for emergencies in case something happens. The size smaller is if the old one falls out and there's trauma or something, they can get it in. They can replace it more quickly, maybe with a smaller one until things stabilize. So. Any other questions?
It's on number 9. It says lubricate catheter tip in NS and verify section.
Mm-hmm.
I thought you're supposed to use the jelly.
No, not on a tracheostomy tube.
Oh.
So the lubrication solution for, if you're going through a nasal or an oral, yeah, it's not going to hurt if you use the, KY or whatever. But if you think about this guy, if you get gloopy, gloppy KY in here, you're just making things worse. It's the same thing as mucus, right? So for the sake of going in this guy, we're just using, now I say KY, we all think of like, is it warming? So what's the other? Surgilube is the other name. That sounds less inappropriate. But anyhow, you don't want that water-based lubricant in here because it will clog up the tube. So you're going to go ahead and just lubricate your suction catheter in the saline a little bit, and that will make it slide in more easily. But if you're doing a nasal or another method, alternative methods, then you're probably going to use the KY, especially through that nose. If you're not using a nasal trumpet, for sure, because that can be really uncomfortable. And when you place a nasal trumpet, you also use it. So, good question. Any other questions or comments? So you guys ready to go in the lab and practice?